Good evening, and thank you for joining us today. We're going to be, I think you're in for a real treat. This is, I think, a very exciting game. And we're going to tackle, talking about management of chronic sinusitis with nasal polyp, looking at emerging biologic therapies targeting epithelial cytokine. It really is a game. And my name is Joseph Hahn. I'm a vice chair at Eastern Virginia Medical School. We have Kate Buchheit, who's at Brigham and Women's Hospital at Harvard Medical School in Boston, Massachusetts. We have Thomas Higgins at ENT Care Center at University of Louisville School of Medicine in Louisville, Kentucky. And finally, we have Stella Lee at Brigham Science Center, Brigham and Women's Hospital, Harvard Medical School in Boston, Massachusetts. And I just want to welcome all the people who are here in the room and also welcome our virtual attendees as well. So I'd like to thank Purview for providing this session. I think this is a very exciting format. I'd like to thank AstraZeneca for providing the educational grant so that we can have this symposium. If you haven't already completed the pre-event survey, you can scan the code and answer the questions, and then during that time you'll be given some Q&A questions during the session. For those who are here, if you scan it with your device and answer the slides and the poll questions, you can also submit questions in there as well. And the virtual learners can also respond it on their screen. So this, if you haven't done it already, you could scan this code. And actually, we have a surprise for you as well. So if you answer the questions and submit questions, you have a chance to win some prizes at the end. So if you haven't done that, please do that so you can do that. And again, thank you, Peerview, for providing the gift cards. So, and then also visit us at peerview.com, Indy 2025, because you can, from there, you can look at the slides. There are also some practice aids that you can use. And then you can, if you need more information, you can email that email, and then you can also follow Peerview on X. And so the goals of tonight is to really improve our understanding of the role of the epithelial cytokines or alarmins and how it relates to chronic sinusitis with nasal polyp. What's the rationale for using biologics or monoclonal antibodies to target these cytokines? We're hoping to enhance your knowledge on the efficacy and the safety of these biologics that target these epithelial cytokines in the treatment of chronic sinusitis with nasal polyp, and also provide some guidance in selecting patients who have chronic sinusitis with nasal polyp and how these emerging biologics can be used in these patients. And so here are the peer pressure rules. So this is a game, and it's a little bit of a competitive game, but I think for fun, and we'll be able to show you who won. The winner is going to be determined by the speed of being able to push the button, but also being able to accurately answer the question. So it's going to be a little bit like Jeopardy. So if the faculty answers it correctly, they get 100 points. If the faculty answers it wrong, they get minus 100 points. We're going to show you a little bit of where they are in the beginning, but we're going to keep it to the end so you won't know who is winning. And then the other faculty, if one of the faculty get it wrong, the other two faculty has a chance to answer that question and get 100 points. And so we'll review the questions at the end of each segment. And so with that, here's a question. Why is targeting epithelial cytokines such as TSLP a promising approach for chronic sinusitis with nasal polyp? Ooh, so people read faster than they. Okay, so all right.
I'm sorry,
Okay.
did
No, you're
we
right.
order the whole thing?
No, yeah.
Because they drive early upstream activation of type 2 inflammation.
All right. Okay, so, all right. I didn't even get to read the question and the answer, but okay, all right. So, next question. Emerging evidence suggests that targeting TSLP may help. Oh, okay, all right.
Because of 3, reprogramming structural cells and altering their interactions with the environment.
Is he correct? Oh, all right. Okay. So next, okay, we're going to look at the leaderboard and see. Oh, did the audience get to see it? Oh, yes, there it is. So Katie 100, Tom 100. All right, Stella, I know you could do it. All right.
Thank you.
Okay, thank you so much. So I'm going to talk about epithelial cytokines driving CRS with nasal polyps and the need for targeted care. So I think this is really background that everybody knows here. About 20% of all comers with CRS have CRS with nasal polyps. And this is really characterized by type 2 inflammation. So these patients have high levels of tissue eosinophilia and type 2 cytokines, which are at high concentrations in the nasal polyp tissue. The other 80% of patients have chronic rhinosinusitis without nasal polyps, and this is quite more heterogeneous. There are many patients who do have type 2 inflammation, but in general, there are more patients with type 1 and type 3 inflammation, a lot of patients with mixed inflammatory endotypes. And for patients who have any reaction to NSAID, certainly those are very type 2 high patients often, and they should be evaluated for possible diagnosis of aspirin-exacerbated respiratory disease, so anyone who reacts to any COX-1 inhibitors. So thinking about the inflammatory kind of immunobiology of chronic rhinosinusitis with nasal polyps, we think about a lot of the inflammation starting in the epithelium itself, which we know is really profoundly dysregulated in patients with chronic rhinosinusitis with nasal polyps. So in sort of normal health, if there is epithelial injury, these alarmin-type cytokines, type 2 inducers like IL-33, IL-25, TSLP, will lead to sort of downstream activation and inflammation. In chronic rhinosinusitis with nasal polyps, in someone who has, again, some sort of genetic susceptibility, there is likely some sort of exogenous insult that starts off this process. But the overproduction of these innate type 2 cytokines can lead to downstream activation of ILC2s as well as Th2 cells, dendritic cells, can lead to production of a variety of inflammatory mediators. We think about the canonical type 2 cytokines, IL-4, IL-5, IL-13, which have lots of important downstream impacts, including mast cell and basophil activation, eosinophilia, mucus production, airway remodeling. These are all quite important in the pathogenesis of CRS with nasal polyps. And a lot of this is really driven in part by these epithelial cytokines. And the type 2 cytokines and a lot of these mediators feed back on the epithelium and cause further epithelial dysregulation. So learning more recently about what TSLP might be doing in addition to sort of activating Th2 cells and ILC2s to produce type 2 cytokines, we've actually learned a lot more about this in the last few years with a lot of different translational efforts that have gone on. So in this study, which was actually Stella and I were involved in, done by colleagues of ours, they did immunophenotyping of a variety of different human cells. And they identified kind of a new cell called the multipotent progenitor cell, which is an activated Th2 cell, which can differentiate into a lot of different T cells with different processes. So effector T cells, follicular helper T cells, T regulatory cells. And what these cells have a big role in is really sustaining type 2 inflammatory responses, which can go on for decades and decades. What's important to note is that TSLP can drive this process. It can actually lead to further proliferation of these cells and activation of these cells, as well as it can render them glucocorticoid insensitive. So really likely has a sort of very broad, important role in sustaining type 2 immune responses. So in terms of what we do know and what we've really learned a lot about already, is, targeting IgE, IL-5, and IL-4 receptor can have impact in treatment of chronic rhinosinusitis with nasal polyps. And this is through actions on a variety of different cell types. So here, we see what blocking each of these mediators does in terms of impacting eosinophils, basophils, mast cells. I think very importantly, IL-4 receptor alpha is broadly expressed on a variety of different immune cells and stromal cells and has impacts not just on sort of the classic type 2 inflammatory mediators we think of, but also impacts on airway epithelium, smooth muscles. It can have an important role in macrophage differentiation, so really broad immune impacts. In terms of kind of moving on into TSLP and what we know about that in chronic rhinosinusitis with nasal polyps, first off, really simply, we know that there are high levels of TSLP at both the transcript level and also protein level in nasal polyp tissues, and that the production of TSLP by epithelial cells is controlled by both actually innate and adaptive immune signaling. We talked about sort of the initial inflammatory insult when a pathogen or other exogenous insult is encountered, but also that the adaptive immune system can signal back on the epithelium to generate more TSLP. And then, we know that targeting type 2 inflammation in chronic rhinosinusitis with nasal polyps also with TSLP can reverse structural changes through sort of reprogramming of the structural cells and the interactions between them and their environment. So before we move on, we'll have a follow-up question.
So you can answer these questions on your device if you've registered for it. And then you can also ask questions. We're not going to take any live questions through the microphone or anything. So if you have any questions, answer it through your device. It'll come up on my screen, and I could see it, and I could ask the faculty any questions that you have. And so, all right.
Perfect. Sorry. Is it okay if I move forward? Oops. Perfect. So back to TSLP in chronic rhinosinusitis with nasal polyps. This is now a study from over a decade ago from the Northwestern group where they measured TSLP mRNA levels in uncinate tissue and then also polyp tissue. And you see that TSLP mRNA levels are highest in the polyp tissue as well as the TSLP receptor. And there's a positive correlation between the TSLP transcript and the TSLP receptor transcript. We looked at this specifically in patients with aspirin-exacerbated respiratory disease and had a somewhat different finding, which I'll explain, which was actually looking at sort of chronic rhinosinusitis as a control compared to patients with AERD at really severe nasal polyps. There was no difference between the TSLP transcript levels in the whole polyp tissue, but TSLP starts off in a long form and then it's cleaved into a shorter active form. And when we did the Western blots to look at the active TSLP protein, we see that there's a lot more in AERD compared to aspirin-tolerant patients with chronic rhinosinusitis with nasal polyps. So we think this certainly has an important role, not just in type 2 inflammatory polyps, but certainly in patients with AERD as well. So, we know that TSLP is produced by epithelial cells. It's found in both the upper and lower airway mucosa. So by really blocking upstream signaling pathway that can activate certainly type 2 and also low type 2 inflammatory pathways in this unified airway, the upper and lower airway. This supports the idea that one biologic in an individual patient may potentially target this spectrum of type 2 inflammation. And so we have one more question. Give people a second to do the QR code. Oh, perfect. So thinking now more broadly about tezepelumab, monoclonal antibody targeting TSLP, and how that works mechanistically in patients with chronic rhinosinusitis. We see here in the portion of the figure on the left-hand side of the screen that, again, the little yellow dots are TSLP, and they're produced from the epithelium. But we see that there is a variety of cell types that they are potentially acting on, including dendritic cells, mast cells. There are actually, potentially some direct effects on eosinophils and fibroblasts, and then sort of the known effect we already talked about on Th2 cells. And so everywhere with the sort of red bar that shows blocking are things that TSLP can stop. And some of these are direct effects and some of them are indirect effects. For example, we know that TSLP can indirectly block production of the type 2 cytokines IL-4, IL-5, IL-13, or mast cell pro-inflammatory mediators such as the inflammatory prostaglandin PGD2. We see that it's blocking that. And then if we look over on the right-hand side of the figure, central to this is the basal cell, the basal epithelial cell, which we know are very abnormal in nasal polyp tissue. They're locked into this sort of progenitor state where they are sort of a very immature phenotype. And we know that if you look at sort of number 1, we know that type 2 inflammation, so this IL-4, IL-13 axis, can drive this uncommitted progenitor state of the basal epithelial cells. IL-4 and IL-13 can drive production of ALOX15. So this is produced from arachidonic acid. When it's cleaved, it can lead to this activation of the ALOX15 pathway and downstream production of 15-heat eotaxin-3, which is really important for recruitment of eosinophils. And then that can lead to downstream eosinophil extracellular traps and more eosinophil-mediated inflammation. And then if you look at number 3, the cystatins can have be involved in an important feedback loop where TSLP can feed back on these basal epithelial cells, again, to produce more eosinophil-related mediators and lead to inflammation from that perspective. So I think that is it. And is it okay to advance, or I'll let you advance?
All right. So now we're done with that one segment. Now we're going to go to some questions. So, are you guys ready?
Yeah.
All right. Okay. All right. So in a phase 3 Waypoint trial, patients with severe CRS with nasal polyp were treated with tezepelumab, demonstrated which of the following outcomes compared with placebo. All right. Stella?
Patients had rapid and sustained reductions in both nasal congestion, nasal polyp size, and good safety profile.
She correct? Ooh, yes. All right. All right. Okay. Then we'll go to the next one. All right. When considering biologic therapy, when considering biologic therapy for patients with severe asthma and CRS with nasal polyp, which factor is most likely to guide the biologic choice based on current evidence? A, efficacy of the lower airway outcome. 2, route of administration. 3, cost-effective analysis. Or 4, magnitude of response in the upper airway outcome. Yeah, I know. Okay. All right. Okay.
Because I'm an allergist, I'm going to choose number 1.
Oh, okay.
Can I choose number 4?
4, is she correct? Oh, okay.
Okay, great. It's like I should.
All right, okay. And then, all right, so let's see why that is. And so, all right, so Stella?
Thanks, Joe. I actually am really so grateful to have Katie Buchheit because she's so talented and so eloquently discussed the pathophysiology of CRS with NP, and so I'm not used to competing against her. It's more like collaboration. Okay, let's talk about traditional approaches. How many of you are otolaryngologists in the audience? I think all of you, right? So, we all know nasal saline irrigations are helpful, that all the ways that we try to deliver topical medications for maintenance, including sprays and various forms for topical steroids. The exhalation delivery system has been helpful as well. It's a higher dose, smaller particle size, so it gets into the sinus a little better. There are these steroid-eluting implants we can place in the OR or in the office. And then what's off-label, all of us do this, but the rinses that we put in, with the different steroids like mometasone or budesonide into as drops or as irrigations. Some of the antibiotics, we've moved away from using that as a primary treatment for CRS with NP, but it can be useful, especially if you're treating exacerbations that are infectious. But still, we know that there's a complexity with the microbiome and CRS with NP, still figuring that out. Leukotriene modifiers, montelukast and xyluten, which is lipoxygenase inhibitor can be helpful, especially in patients who have AERD. And then systemic steroids, we really try to avoid using them. Even in my practice as a doing sinus surgery or any surgery, our anesthesiologists, how often do they ask you, oh, I'm going to give like 10 of Decadron, and now I'm like, no, don't do that. Like, why? And they're like, aren't you worried about nausea? And I'm like, well, I don't want the patient to have long-term, toxic side effects. I'm thinking more of systemic steroids like radiation, even, that it does have a cumulative effect on patients. So for sinus surgery, when all of our medical treatments are unsuccessful, the goals of surgery, we know it's not a cure, but it can really, for CRS with NP, it can really help patients remove that inflammatory burden of polyps, help them breathe better, help them feel better, reestablish the outflow tracts. And I talk about sinuses, kind of allude to them like big auditoriums like this and small apartments, and regardless of each compartment size, each of them has a 1 millimeter door. So the goal is to reestablish those tracts and allow for better access for topical delivery into the sinuses. And then so important is not just the surgery itself, right? Is what the patient does after the surgery. So I tell patients we can do the most meticulous surgery, but the post-surgical maintenance is just as important. And this is a chronic condition, CRS with NP. The problem is recurrence. And, with the recent meeting with the ARS that we had too, we heard some nice talks. It still is a problem. Polyp recurrence can range from 10 to 40%, and definitely more common in patients who have AERD, who have comorbid asthma, who have comorbid allergic rhinitis, and that's been already shown, by other studies. And you can see some of the older studies too, the polyps recurrence rates vary, but they are high. I mean, like 40% is like just not acceptable. However, with extended approaches, especially there's some nice papers out there that show that when you are more aggressive with surgery, with things like graft 3, and the whole point of this surgery, right, is to allow for better access for topical steroids, the recurrence rates are better. But the thing is, when patients have mixed inflammation, as Dr. Buchheit, alluded to, there's so many different types of inflammatory cell types, and we're talking more about endotypes, which is like knowing the mechanisms of inflammation, which is really important because, how many of you have heard of TSLP? It's just more recently that I think we're trying to get the word out that it's so important. But mixed inflammation with neutrophilia, and it's not just eosinophils, right? It's maybe the whole burden of inflammatory cell types, and I think we need to move away from just looking at eosinophils. So currently approved biologic therapies for CRS with NP, this is one of the, it's an important slide because when we make that decision, I make the decision with Katie, I don't make the decision by myself. We obviously with the patient too, but if the patient has other comorbid conditions, it can help make the decision about choosing the appropriate biologic for that patient. And it's a clue that for that patient that there's a specific inflammatory process happening that can be driving the impact on the patient's quality of life. So definitely it's important to be aware of these other indications for these biologics, for the 3 that are currently approved, and that can help make the decision on which biologic for which patient. I'm going to briefly go over this. I know many of you already are familiar. These are the 3 pivotal clinical phase 3 trials. The Liberty Sinus 2452 study for dupilumab, Polyp 1 and Polyp 2 for omalizumab, and Synapse for mepolizumab. And the primary outcome measures are nasal polyp score and nasal congestion score. And you can see on the first column, the treatment group is in blue, and compared to placebo, a nasal polyp score of about 2-point change. And all of you are familiar with what nasal polyp score means, kind of. So you can have a total of 8, 4 on each side is the worst. 4 is a complete blockage with polyps. So polyp 1, polyp 2, about 1 point difference, and Synapse also about a -7 difference. So nasal congestion score also, you can see there for dupilumab, it was about 1.4 to 1.6 change. It goes from 0 to 3. And then you can see the also with polyp 1, polyp 2. And I won't belabor some of because it seems that for all of these biologics, they were effective. But when you look at nasal polyp score, nasal congestion score, they all helped, but some more than others. So going to some of the adverse events, this is really interesting. It's a more recent study just published last year. And I think all of us need to be aware of this because some of these symptoms can be a little bit more vague, like joint pain, for example, or you can see arthralgia was one of the top adverse symptoms, and we're seeing this also in our practice and trying to help patients through it. But for this study that looked at mepolizumab and dupilumab, you can see the arthralgia was quite high, and like skin reactions, we've seen that besides rash is so vague, but skin reactions can also happen, so we need to all be aware of those side effects. All right, so Waypoint was a study that's already published looking at tezepelumab, which is an anti-TSLP, and we were one of the sites in Massachusetts, and we were able to see, looking at the data look really amazing. We're also seeing this hopefully in the real world soon too, regarding, not just nasal polyp score and nasal congestion score, but really helping patients breathe better, smell better overall. So with their asthma, this is already approved for asthma, I believe approved in 2021. So the change from baseline versus placebo was 2.07 for nasal polyp score and about a 1-point change for nasal congestion score. So going to the next question for our attendees. Oh, did we need to go back?
No,
It's fine? Okay, keep going.
Yep,
All right.
yep.
So this is a great representation of how certain, especially tezepelumab, can help decrease the use of systemic corticosteroids. The orange line is the placebo, and the blue is the treatment group. On the left is the decision to go forward with sinus surgery, and on the right side is the need for systemic corticosteroids. And you can see that during the trial, the patients who were on the treatment group, tezepelumab, had a significant decreased need for systemic corticosteroids, and also didn't need sinus surgery as well. And if you look at some of the key secondary endpoints, loss of smell, and also I wanted to point out UPSIT too, quite impressive as regarding patients' ability to smell again. They were feeling much better. The interesting thing is, so the column that you want to look at is the difference, I think, versus placebo. So you can see that sometimes there is a placebo effect, and some patients just do better just by seeing you too and being adherent to topical corticosteroids. But it's not 22 score, but at least a 27-point drop, and Lambda-Chi score over 5.5, and total symptom score, but UPSIT also almost a 10-point improvement in UPSIT score too. And overall, adverse events were quite similar between placebo, very well tolerated. I'm going to talk a little bit more in a little bit about the emerging therapies, depemokimab and stapokibart. I know it's like alphabet soup. But depemokimab is an ultra-long-acting anti-IL-5 agent, so you only have to give it twice a year. It's a very high affinity, so some of the clinical trials that were done, Anchor 1 and Anchor 2, showed that there was significant improvement. They did show significant improvement to nasal polyp score and the nasal obstruction score in the depemokimab group versus placebo. And same with stapokibart, which is similar to what dupilumab is doing, but it is binding to the ligand in a little bit different way. So there is a nice study out there, the Crohn's 2 phase 3 study, that showed that patients also had significant improvement in need for decrease in nasal polyp size and decrease in symptom scores. But interestingly, the adverse events were a little bit higher for arthralgia, even though they were rare. So you can see arthralgia 7.8% and hyperuricemia too. So we really do need to understand the differences and the potential side effects for these medications, especially if they're very long acting and also if they're slightly different from what we are used to. Going briefly over some of the data from all of these trials, if you just summarize it all together, you can see all the ones that are really important to know about. And this is looking at the nasal polyp score. So on the bottom is going from 0 to all the way up to 3. And it looked like the biologics that performed the best, you can see dupilumab is up there, as well as tezepelumab. On the bottom there, about a 2-point change nasal polyp score, and also nasal congestion score, dupilumab and tezepelumab. But it does seem like all of these medications, except for benralizumab, did not do so well and did not get approval for CRS with NP. That's important to know. But the 3 biologics are currently approved, and it looks like tezepelumab did quite well and performed quite well. So in general, for patients who have this high type 2 airway disease, both for asthma, for CRS with NP, we have to choose the biologics wisely. We need to be guided by some of the responses. And I know this is a bit confusing, but I think in general, it does require a multidisciplinary conversation with our colleagues and understand what it's doing for asthma, but also what it can be doing and helping our patients with CRS with NP as otolaryngologists, because that's really important for our patients. All right, so to our next question.
Okay, so all right, question to the faculty. Which statement best reflects the current understanding of the role of surgery in relation to biologic therapy for chronic sinusitis with nasal polyp? 1, endoscopic sinus surgery eliminates the need for biologic therapy in most patients. Okay, Tom.
Go with 3, surgery may improve biologic penetration and outcomes in some patients, but does not address underlying inflammation alone.
Oh, he's correct. All right. Oh, it's getting close. All right. Next question. Which of the following patients with chronic sinusitis with nasal polyp would be most appropriate for consideration of a biologic agent? All right. Katie.
All right, I'm going to go with a patient with recurrent severe CRS with nasal polyp despite prior surgery, ongoing intranasal corticosteroids with comorbid asthma.
All right, Katie. Great job. All right. Next one. All right. I think this is our last question. When assessing response to biologic therapy in CRS with nasal polyp, I can't even finish the questions. Okay. All right. Which of the following outcomes is the most clinically meaningful? Katie.
I have to catch up from the one I got wrong. So I'm going to go with 3, improvements in nasal polyp score, congestion, and quality of life.
Wow. Now, I really don't even know the score, but it looks pretty close. All right. I think it's yours. Okay.
Need the clicker. All right, thanks. So I'm going to go into identifying how you identify patients for biologic therapies. So the selection requires a couple of different aspects that you need to look at in your clinic. Obviously, you want to confirm that you have a diagnosis of uncontrolled severe chronic rhinosinusitis with nasal polyps, and you want to look into those comorbidities. As we said, that they can play a role, especially in the intensity of the inflammatory process. So asthma, NERD or AERD, you want to look into. And then check that type 2 inflammation is highly likely. We'll go into that a little bit more. And then you have a talk with the patients. There's a lot of things that they may be going through. And so you can go through these treatment options, both medically and surgically, figure out the history that they've gone through, their journey with their condition, and the perspectives and risks of each of the treatment options. And so that shared decision-making comes up, whether or not you're going to proceed with a surgery or biologic drug, or if there's a combination thereof. And then at that point, now you're selecting the biologic medication of choice. When you're dealing with people with chronic rhinosinusitis with nasal polyps and asthma, you may want to collaborate with your allergists or pulmonologists who really have vast knowledge and experience, particularly with asthma, and they like to collaborate with you as otolaryngologists, especially if they have the less experience with the chronic rhinosinusitis with nasal polyps, and so I think that collaboration can be really key. So, how do you determine and identify the patients that are candidates for biologic therapy for CRS with NP? Now, the EPOS and euphoria criteria are here, and this is one way of potentially identifying it. A panel of experts kind of looked into this. And so they looked at it and said, if you have the presence of bilateral polyps and in a patient who's had endoscopic sinus surgery, then looking at least 3 of the criteria would be important. So, for instance, evidence of type 2 inflammation. We just discussed that. One way of doing that is tissue eosinophilia, greater than or equal to 10 per high-powered field, or blood eosinophils of greater than or 1 equal to 150, or total IgE greater than or equal to 100. And then look at the need for systemic corticosteroids. We just talked about a lot of the risks that corticosteroids can have and whether or not they have contraindications for systemic corticosteroids. And we've found that even just 2 courses or more a year can really elevate the risk of side effects. And especially long-term, over 3 months of low-dose corticosteroids can have an effect on the body. You want to also look at the impaired quality of life. I don't know how many of you all do the SNOT-22 assessment. That's one way of a validated way to look at it. Greater than 40 or equal is considered severe disease. So looking into that can be a good way of assessing the severity of disease. Significant smell loss is a significant one. We historically haven't looked at smell loss as much because people who seem to have chronic rhinosinusitis, nasal polyps, have a gradual onset of their smell loss. And so they don't really bring it up all the time. But once they identify that smell, things can change. And so being able to assess that patient who's anosmic is important consideration for their therapy. And then diagnosis of comorbid asthma, as we mentioned, is important, and considering regular need of, especially if they have regular need of inhaled corticosteroids. So a published stepwise treatment algorithm looked at the management of chronic rhinosinusitis with nasal polyps. And in looking at it, you want an escalation of treatment, especially if refractory. So a lot of the patients will get sinus surgery. And you can look at the extent of sinus surgery, can be helpful. But also sinus surgery allows access to the sinuses, also differential diagnosis. The last thing you want is a tumor to not be treated in a timely fashion. And to evaluate, there could be comorbid infectious process and everything else, so sinus surgery plays a role. And then the postoperative management with saline irrigation, steroid irrigations, EDS flu, steroid sinus implants, are options of maintenance because we know it's a inflammatory condition, so kind of seeing how well they do. Now, if symptoms start to persist or recur despite the sinus surgery, it's good to follow the patients over time, because that way you can catch them at that point, so to identify what the next step in management is for them. So biologics might be indicated, and a revision sinus surgery is an option, aspirin desensitization, particularly for the patients with AERD, steroid sinus implant, and short bursts of oral corticosteroids are all options, and then look at the response or persistence of disease. If you're not seeing a response in your therapy, particularly biologics and aspirin desensitization, you want to kind of reassess of what you're doing, if there's going to be a different type of therapy, different biologic that you consider, or different management. In a minority of patients, there's just a contraindication for surgery in particular, or they have poorly controlled asthma, and it's very difficult to get their symptoms under control, especially they're oral corticosteroid dependent, or they might even decline surgery. So in that option, there may be consideration of particularly biologic right up front, and seeing how they do from there, again, following the patient over time. And when we look at biologic use amongst patients with CRS with NP, it seems to actually be low if you look at a retrospective cohort study at this time. And you can see that the all-cause oral corticosteroid use across 24 months after biologic initiation can be high, and only 12% receive approved biologic. And so now you're getting more corticosteroids, more antibiotics, more surgeries. All of those are a consideration. So recognition of the patient, and again, following the patient for their symptoms to see if they are indicated for further escalation of therapy. So who's best suited for this anti-TSLP therapy, and why? Patients, particularly with recurrent, persistent, severe chronic rhinosinusitis with nasal polyps, despite optimized intranasal corticosteroids and prior endoscopic sinus surgery. TSLP, as was described, is an upstream epithelial and so-called master switch. So it's where everything starts at the barrier, and it prevents the rest of this cascade from occurring. So a broader inflammatory network and modulating that. Coexisting uncontrolled type 2 airway disease. So you have asthma, you have AERD, and they remain symptomatic despite all these therapies. And so it can potentially impact the structural epithelial remodeling. And data from the Waypoint study shows a rapid sustained improvement in nasal congestion score, nasal polyp score, including patients with comorbid asthma. Another indication is steroid-dependent patients. We talked about the risks of steroids several times, and those who fail surgery or are at high risk for it. And inadequate control from the other biologics, if it's anti-IL-4 alpha, anti-IL-5R, or anti-IgE. And you may look into what is the options from them and look to see if it's a pathway selection of biologics for incomplete control or adverse effects. So we'll take a moment for questions. All right, so how do we define the biologic therapy? Like, meaning, does it work? What's the response in chronic rhinosinusitis with nasal polyps? So this was looked at, if you look at these 5 criteria, and an easy assessment of saying whether or not it's a good to excellent response. They have 4 to 5 criteria in there. A poor to moderate response, 1 to 3 criteria, or no response. And so if you evaluate these 5 different elements, so reduced nasal polyp size, reduced need for systemic oral corticosteroids, improved quality of life, improved sense of smell, or reduced impact on comorbidities. And you can evaluate that, and again, evaluate that after 6 months again, see if there's a good response, partial response, no response. And then you can also evaluate it after a year, again, following the patient to see how they do, because then you can make critical decisions for them to make sure they maintain good therapy and good results. If you're not getting a response, you discontinuing the therapy and try to see what options there could be. We'll take another moment for a follow-up poll. So you look at different types of responders, a partial responder, a complete non-responder. And when you evaluate that, we talked about some subjective and objective criteria that didn't see if there's some improvement in there. And at that point, you can continue the therapy, monitor, see if there's anything further to kind of escalate, but consider either a dose taper or stable in response. And if they're a complete non-responder, meaning no real meaningful symptom relief, polyp reduction, you might need to do something else. And so the option's going to be, switching biologics, or does it require surgical intervention? We know from otolaryngology and our evaluations from nasal polyps, is there scarring in the sinus cavity? Is it just inflammatory disease? Looking at the structural versus inflammatory process to see what is the next step for you. And sometimes there could be a combination thereof. So can biologics be used without surgery? Well, there are several trials that include patients with and without prior functional endoscopic sinus surgery. And there is efficacy for both groups, suggesting that surgery is not always a prerequisite for biologic benefit. But you want to consider, again, the patient that you see in front of you, the nuances that you see, and what's going to be best for their therapy. So before surgery, biologic can reduce inflammation, reduce polyp size, and potentially lower the surgical burden. So whether or not you do surgery at that point to now further help reduce disease burden. And then after surgery, now you're trying to maintain polyp control. You're trying to keep the inflammation down, reduce recurrence, keep them away from the corticosteroids that can cause all those different side effects, and minimize the need for revision endoscopic sinus surgery in the future. And so this is an ongoing discussion. I think it's a great discussion, and it's a discussion not only in a broader sense amongst your colleagues, it's also a discussion between you and the patient. Some of the patients every patient has some unique things going on, and some you want to consider what their opinions are as well. All right. I'll give it a moment for the follow-up poll. All right, in summary, so chronic rhinosinusitis with nasal polyps, it's a type 2 inflammatory disease, and we've seen that. We've seen the cascade and how it works. It's often refractory to conventional approaches. And so we want to look at the quality of life. We want to evaluate the comorbidities, particularly asthma, as a consideration of how severe the inflammatory process is in that patient. And there's a few currently approved type 2 directed biologics for chronic rhinosinusitis and nasal polyp, including dupilumab, omalizumab, and mepolizumab. There's also a consideration of the epithelial lining, the barrier, where the signaling and alarmins will start the cascade. And so these epithelial cytokines, especially TSLP, are elevated in chronic rhinosinusitis with nasal polyps, and they drive the type 2 inflammation. And so tezolizumab is a biologic in development, and it shows that rapid, sustained improvement in congestion and polyps size in randomized controlled trials. And so other biologics are also under development, as we've all discussed. And so looking at those options in a personalized management so you can have the best outcomes for your patients.
Great. Thank you very much. And that was, I think, a great overall comprehensive message, I think, in understanding on how these epithelial alarmins affect our nasal polyp, and by targeting it, what does it do? So now we have actually lots of questions for the faculty. And so I'm going to kind of go through it, and I'm going to ask the first question to you, Katie. The question is, the greatest concern with these drugs is the potential effect of the immune system. Please discuss any potential long-term issues. Are there any long-term issues?
Yeah, I think this is a really important question. And I have this discussion with, I'm coming from the allergy perspective where I have discussion with my patients, for some of these drugs, specifically certainly tezepelumab, dupilumab, we don't have decades and decades of safety data. So if you are someone who's a good surgical candidate and you haven't tried that yet, I refer them to my rhinology colleagues so they can have that discussion, because I think that it is important sort of risk-benefit discussion to introduce that concept to your patients. In terms of, the question was impacts on the immune system. So we don't see actually any of these sort of biologics that target type 2 inflammation as being immunosuppressive, particularly, with the exception of seeing, I think rarely in some of the studies, and I've seen it a few times in practice, patients developing HSV infections or shingles. Otherwise, we haven't seen a ton of immune suppression. We don't, think about it really impacting cellular immunity very much, antibody production. We don't see like recurrent sinusitis or pneumonias or whatnot as a side effect. So, we don't think of these being immunosuppressive the way we see, biologics that target rheumatologic disease or malignancies being very immunosuppressive, which is good for patients. In terms of the overall kind of broad immune targets, I have the discussion with my patients that, yes, we don't have decades of safety data. These are drugs, especially when you think about something like dupilumab. You have IL-4 receptor on lots of different cell types, both immune and non-immune cells. Are there going to be sequelae down the road that we yet have not identified because we haven't had someone take this drug for 30 years? We do have that as a discussion. We know that, having 10 sinus surgeries is bad, and being on steroids every single day of your life is also bad. So I think, weighing some of the very small unknown risk versus the really profound benefits these patients get is important. But yes, they are, not immune suppressive in the traditional sense where patients are going to get recurrent infections, but do certainly have impacts on the immune system.
Okay, thank you. Next question is for Tom. A new patient with nasal polyp, does he require surgery or just a biopsy?
That's a great question. A biopsy can be misleading. So particularly if you're thinking about a simple biopsy, say in the clinic. Too often we see other differential conditions that come into play. So particularly even if it's bilateral, it's less likely, but particularly if it's unilateral, you start to worry about tumors. And so sometimes those tumors are further in the sinuses than you think. You have to be leery of allergic fungal rhinosinusitis, for instance. We don't have much evidence right now that say that the biologic will completely treat that. I think it reduces inflammation. I think it's a wonderful option after surgical intervention, but you have to be careful with that because it will expand further outside of the sinuses to the eye, to the skull base. So considering that. Also, there's in general, if we also know that endoscopic sinus surgery is highly effective. There's been 2 cost-effectiveness studies that have shown that endoscopic sinus surgery actually is cost-effective versus biologic up front. And I think reducing that burden of disease is important. And you're also going to catch a certain number of patients who never need a biologic. As I talked about the escalation of care. So once you've done surgery, just like asthma, what's the first treatment of asthma is as needed beta agonist or a daily steroid. It's not necessarily the biologic. The same is true for managing chronic rhinosinusitis with nasal polyps, that if you do surgery and the only thing that they need is a nasal steroid spray, and that's not always the case, but then that's all they need.